Right, I'd like to thank our chairs for inviting me to give this talk, particularly because the pioneer of Tapinarof research is sitting here with us today, Robert Bissonnette. So that was very kind for you to ask me, and I'm happy to be here in Milan, who isn't. So is this working here? My disclosures, I work with most companies doing clinical trials. The relevant ones would be GSK for this molecule, as well as Dermavant. And the objectives are to look at these targets, the new targets for topical therapy in the pipeline, but I only have a short period, so I'm really going to focus on Tapinarof this afternoon as a treatment for AD, looking mostly at the safety and efficacy of this molecule. But first, I want to bring it back to the clinic, and I think any of the clinicians out there will agree with me that we have these patients sitting in front of us and we think we should be doing a better job at treating these patients. Here's a patient of mine who still has active disease on her face and neck. She still has active disease on her wrists, but you can see in her antecubital foci a number of striae, which is like marks from years gone by where she has been overusing topical steroids. So she has signs of previous use of therapy, but still has ongoing active disease. And I think these are the patients that we need to do better and find more treatments for. So this is a chronic inflammatory loop that I think we probably all think about in our sleep every night. This is from a very nice review article showing, does this work here? Showing the barrier involvement in this chronic inflammatory loop, as well as the inflammatory system, and not forgetting that there are other components. It's not just a barrier and an inflammation loop. There are other factors such as the microbiome, sensory nerves that you've already heard about earlier this afternoon with Dr. Paller's talk. So when we look at what is available or coming for treatments for atopic dermatitis. This is from another review article that I've added some at the bottom. This is a nice review on topical therapy in AD, and you can see a number of agents in the pipeline, and that is because for patients like JB, we need to find new therapies. So you've already heard about the PDE4 inhibitors with Dr. Eichenfeld. There's a number in development. Some quite impressive results. Next, you will be hearing about the JAK inhibitors from Dr. Tachi, and there are more than listed here. This review is a couple years old. This list has expanded significantly. And then you have these other category where it's a number of different targets that are being looked at. Kind of the new kid on the block is a cannabinoid receptor, BTX1204. I don't know about any other countries, but cannabis is now legal in Canada, so most of our patients come in asking for something in this pathway. So it's nice that these agents are being investigated in a randomized controlled fashion. But today I'm going to be talking about Tapinarof, which has also been called benvitimod. So going back to this chronic inflammatory loop, a lot of what we hear about lately is targeting the immune system. You heard about it with the PDE4 inhibitors. But really, all of the agents that I just showed you are targeting different areas. So they're targeting the barrier, they are targeting the immune system, but they're also targeting what's in between with the microbiome and the sensory nerves. So the difference with systemic therapy is with the keratinocyte, we can target it directly. And this is another figure from that review paper that I thought was very nice because we have lately been so focused on, at least I have been, in my reading and in our research about targeting the immune system, which of course is very important, but we can't forget there are a number of things going on in the keratinocyte. On the right-hand side, in yellow is atopic dermatitis pathways, and then the blue is psoriasis on the left. But you'll see here, we talk a lot about JAK inhibitors in a number of different disease states. We just heard about the PDE4 inhibitors. But the other thing I liked about this figure is that for the first time in what I've been looking at, I see the aryl hydrocarbon receptor and how it has a role here in the keratinocyte. It also plays a significant role in the immune cells as well. for signaling. But because we're doing a focus on other immune pathways, I thought I would focus this on the keratinocyte. So the aryl hydrocarbon receptor activation restores filaggrin expression, and this FICZ, I guess it's called FIX, is one of the ligands for the aryl hydrocarbon receptor, and when it binds to AHR, it translocates to the nucleus to activate OVAL1, and that leads to filaggrin expression, which is, I think, important in this condition, obviously. And as Robert spoke about earlier, with the maximal use study, with the 2%, 1%, 2% BID application, there was actually a decreased absorption over time, and it's felt that improving the barrier, increasing filaggrin expression, is improving that barrier and reducing the absorption over time. The other interesting thing is that interleukin-4 leads to decreased filaggrin expression, so opposing that is this aryl hydrocarbon receptor. So basically, Tapinarof is a therapeutic, they're calling this a TAMA, a therapeutic AHR modulating agent. It's in a number of different cells, as I mentioned, but it binds to its receptor, is the ligand for the receptor, which enters the nucleus, like any sort of signaling pathway that we talk about leading to gene expression. So that will depend on what the ligand is that's binding to the receptor, as well as what cell type is being affected. So in the case of Tapinarof, if it's in the Th17 cell pathway, you're going to get a reduction of Th17 cytokine expression. If it's in the Th2 cell in the pathway, you'll get a reduction of Th2 cytokine expression. This is why it works in both psoriasis and atopic dermatitis. It also decreases oxidative stress, and as I just showed you, can increase skin barrier protein. So it has a multimodal mode of action important for this condition that has multiple causes. So, as I mentioned, it's had a few different names. It started out as WBI 1001, which Robert showed you earlier in his talk. GSK then named it this number. It's been called benvitimod. I still don't know where that name came from, but I think they've landed on Tapinarof. I hope they don't keep changing it, but all of these are the same thing. And I remember, I think it was at the AAD or the EADV a couple years ago at the Late Breakers. One person came up and gave a talk on benvitimod, and the very next speaker gave a talk on Tapinarof. And then it wasn't until afterwards someone said, I think that's the same thing. Anyway, I think that was Christian Reich who pointed it out. Anyway, that was, it's hard to follow the research when they're changing the names, but we've finally done it. So Tapinarof has a bit of a history. This is not a new agent, as Robert pointed out earlier. He was doing research on this molecule more than 10 years ago. It used to be owned by Wellchem Biotech, which is actually a Canadian biotech company. And the research that was done by Robert and some other Canadian researchers. And then in 2012, it was acquired by GSK. They did another phase 2 program. And in 2018, the rights were taken over or purchased by, I never understand how that business side works, but it's now in the hands of Dermavant, who is planning the phase 3 program. So this, I won't spend much time on. Robert already showed. This was the first single center study that he performed back in 2009 on 37 adults with a BSA of 1 to 10%. And you can see in this phase 2A study the improvement, the reduction in EASI, SCORAD, BSA, pruritus, with some nice photographs comparing to vehicle with the 0.5% cream and the 1% cream. Significant improvement over the 4 weeks of this short 4-week study. So this was enough to kind of move on to the next stage and do this multi-center trial that was done across Canada at a number of sites for 12 weeks in a larger group of patients. And here was the study design. It was in adults with a BSA from 3 to 20%, an IGA of 2 to 4. The target was 150 patients. So you can see the randomized 1:1:1 vehicle, 0.5% BID or 1% BID up to 6 weeks, at which point the placebo or the vehicle patients were then re-randomized. It remained blinded to the 0.5 or 1% for the second 6 weeks of the 12-week study. And here is the primary endpoint shown with the green arrow. You can see a nice dose response with the change from baseline in IgA. And then at this point, these patients were re-randomized, and you see again the same dose response in the second 6-week period of the 12 weeks. And those patients that stayed on their dose continued to improve. This is showing the treatment response, so an IgA of 0 or 1 with a 2 or greater improvement. And you can see the most effective dose being the 1% cream at the primary endpoint, which was 42 days, continuing to improve over time over this 12-week study. So after that, the molecule was then acquired by GSK, who developed, I think they may have improved the consistency of the vehicle. I think they made a bit of changes in the product itself. And then they had to repeat the phase 2 study and trying to determine was a BID application required versus OD, once a day application. So the randomization was between 1% once or twice a day, 0.5% once or twice a day, and then vehicle once or twice a day. And they had already been doing the maximum use study that Robert had presented earlier, where they had a 2% cream that went up to 35% body surface area. So we'll see the primary endpoint again being treatment success of IgA 0/1 with a 2 or greater improvement from baseline. So these are the baseline characteristics of this phase 2b study, and although there were some, the study groups were only about 40 per, so there are some minor differences in things like the BSA. The IgA was pretty consistent, slight variation in the EASI score, but overall the groups were fairly similar. Here's the primary endpoint of the IgA response. And so the dose moving forward, just so when you're looking at these graphs, what is going to be most relevant is the 1% once a day, which is here in blue. Okay, the twice a day is in green, and you can see they kind of follow together in all of these graphs, so that the extra application per day is not necessary for efficacy. And as you heard earlier, with the 2% BID application in the maximal use study, there were dropouts for things like headache, nausea, vomiting. So you do get more side effects with higher dose, and if you don't need it for efficacy, then we'll use the least amount that we can for efficacy, which is 1% once a day. And then the two purple lines are the 0.5% once or twice a day. And again, you can see they're fairly similar in most of these graphs where the second application per day is not helping with efficacy. Oh, the other thing about this graph is that you see this statistical significant difference at week 4. And as you saw from the very first study with a photograph at each week, you can see improvement throughout that 4-week period, but it is statistically significant by week 4. EASI 75, again, we see the blue line, which is the 1% once a day, with at 12 weeks, about 50% of patients meeting that EASI 75 point. With pruritus, there was not a great difference. There was no difference between 0.5% and 1% cream over time, but they were all significantly better than vehicle application. And again, if you look at this, patients who were very or moderately improved in their symptom severity, the 1% and the 0.5% are similar in the total very or moderately improved, but the solid part of the bar is very improved. So you can see there's a greater proportion of the patients in the 1% are very improved compared to moderately improved. Whereas with pruritus, it was fairly equal between the 0.5 and the 1%. As I showed in the other graph, all of those lines kind of landed together, but more improved than vehicle. So here are some photographs from that publication in the JAD showing the Tapinarof 1% cream once daily and the improvement over 12 weeks. So you can see significant improvement by week 8, which continues even more in week 12. In the bottom case, it's It's quite lichenified at baseline, and you can see that significant benefit by week 12 with improvement even with the lichenification. So the one thing we always, we're talking about maximum use and 2% and people dropping out because of headache, things like that. What are the AEs that we need to think about in the 1% once a day group that we are going to move forward with a dose? So I think this study is very favorable for the AE profile if you look at the 1% group. So first of all, if you look at serious adverse events or severe adverse events, there were none in the 1% group, which is reassuring. As for serious AEs, the only one was in the BID group. But so this blue, again, is the group moving forward. And compared to the other dosing groups, it's favorable. The one thing that really does show up in every study with Tapinarof, even the early ones, with the maximal use study, 50% of patients had some form of folliculitis, but that is the main difference that we see between the Tapinarof groups and vehicle. There were no folliculitis in the vehicle group and the highest amount in the Tapinarof 1% group. And having done the trials, it's not a folliculitis just where they're putting the cream. It's not like an occlusive folliculitis. They have some form of inflammatory response with a folliculitis that's even outside the treated area, at least in the patients that I saw. But something moving forward in the phase 3 program, and we have more patients and a longer period of time that hopefully will be better delineated. Just the other thing to point out here, the headache, which was an issue with the higher dose groups, the BID 2% application for maximum use, headache was an issue, and you do see a few more headaches in the 1% group compared to the vehicle group. So to summarize, the IgA response is 46% in the 1% once a day group after 12 weeks. The EASI-75 was 51% at 12 weeks. We did see a significance as early as 2 weeks with the EASI-75, but the greatest difference was at 4 weeks. A higher proportion of patients had reduction in itch compared to vehicle, but not compared to the 0.5% group. And the safety and tolerability at the 1% once a day dose, it is very safe and tolerable, but we do need to follow things like folliculitis. So I have hopefully introduced you to a new mechanism of action today with the aryl hydrocarbon receptor. It actually works very well. I think it's very safe at the doses that we're going to be using it at. And I think for the phase 3 program, we really need to look at these AEs of folliculitis. And also in the earlier studies, there was a question of contact dermatitis. Again, that was outside the treatment application, which doesn't quite make sense. So these are issues that will need to be teased out in the phase 3 program, which should be starting soon. And so I'd like to thank you for your time and have a wonderful time in Milan.